So thank you for having me here today. North Carolina is a one of the smaller southern states, and I'm from Winston-Salem and Wake Forest, and I know there's been a few connections here over the years, so thanks again. Today we're going to talk a little bit about total elbows and then follow that up with complications related to total elbows. This is the only Greek I have, so I'm sorry about that. But when it comes to elbow arthroplasty, arthro comes from the Greek arthron, meaning joint, and plasty in terms of molding or formation. And so one of the things that I point out to our residents is that this includes more than just the replacements with metal and plastic. It's any kind of reshaping of a joint, and it includes the last talk in terms of posterior impingement. And we love being total joint surgeons because it's straightforward. So total elbows started out in 1973 with Roger D. in London, and he had a constrained hinged elbow replacement. And it was not so successful because of the constraint, and we'll talk about that a little bit further as we move along. But the constraint caused loosening, and by 3 years, 25% of the humeral implants had loosened and required revision. And that's something that over time has resulted in debate about how to approach that. So today, for this part of the talk, we're going to talk about the indications, the biomechanics, how we do this, as well as the results. The main goals when we do elbow replacements is first, pain relief. Second is improved range of motion. And then lastly is stability. And you'll see that when we start looking at some of the cases related to stability, whether it's the fact that they have ankylosis or they have instability, those are the most challenging issues in terms of outcomes and lasting worthwhile outcomes. So what are the things that we typically treat for this? The basic ones that we treated for a long time were inflammatory arthritis, rheumatoid, psoriatic, and hemophilia. Unfortunately and fortunately, especially in the US, we don't see this very often as much as we used to, because so many of the new medications that are available, including Humira and Enbrel, have really eliminated a lot of the bad inflammatory arthritis outcomes and causes. The other is acute fractures, and this for a while was increasing in incidences of our use, but we've become a little bit less enthusiastic about it now as outcomes lengthen, and then people are wearing these out over time. And we'll talk about that a little bit more. And then lastly, as a primary diagnosis, is osteoarthritis, which is fairly uncommon. And the most folks that we see this in are usually younger folks in their early to mid 40s that have heavy labor jobs, that a total elbow is really not a reasonable treatment option for them. Secondary diagnosis include traumatic arthritis, humeral non-unions and malunions, instability, as well as ankylosis. And some of the ones towards the bottom are examples of really complicated problems that generally don't do as well. And then last is obviously a failed total elbow arthroplasty. So this is the Fortress model, just as for the basic understanding of elbow mechanics, and we'll go over this a little bit more detail later with soft tissue injuries. But this was developed by Sean O'Driscoll at the Mayo Clinic, and it's a good way to kind of think about the elbow in terms of what's important. And essentially the three primary restraints are the turrets on the outside of your fortress, and that's the ulnar humeral articulation, the LCL and the MCL. And then the secondary stabilizers are the radiocapitellar joint, as well as the muscles that include the common extensors and common flexors. And so what you're trying to address, whether it's in arthroplasty or whether it's in a soft tissue repair from an injury, is you're trying to address the three primary restraints. One of the things that was missed initially with Roger D's implant was the idea that the elbow, in terms of varus and valgus, has a little bit of give. And so when they made that original elbow, it was so tight with no give, it caused a high stress on the implants and they loosened. So this led to the development of the sloppy hinge, in terms of the Coonrad-Morey design, and we'll talk about that in terms of the development with the complications. But the sloppy hinge more appropriately reproduced the elbow in terms of its varus valgus and rotational changes. Another important effect is understanding that when the elbow flexes, there's a posterior vector that drives it posteriorly. So the coronoid is very important in this way to keep the elbow from sliding posteriorly. This is a particular problem when you have complex elbow instability problems and you have difficulty reconstructing the coronoid. And then finally, with distal humeral condyles, there's a mixed approach to this. In the short term, when McKee and the folks in Canada looked at this, they showed really no difference for the implants if there was condyles or not. But one of the things is that it was really only short term, and the study never evaluated implant survival. And so one of the concerns long term with this may be that the condyles are important in terms of rotational stability to the implant when they're not available. So how do we do these? They seem complicated sometimes when you look at the x-ray, but technically they're not as complicated, nor is the instrumentation quite as precise as you'd expect, especially when you compare it to something like a knee replacement. But we position these patients supine or lateral decubitus, the incision's posterior midline, and then we classically and regularly transpose the ulnar nerve unless it's been transposed for some reason in the past for previous surgery. And this is essentially the superficial approach that you see here. When you get to the deep exposure, you have to address the triceps, and there's two different ways you can approach it. The traditional way in the US has been the Bryan-Morey triceps reflecting approach, and we'll talk about what the downsides of that approach are, both in the early postoperative period and the long-term postoperative effects. And this can be used for anything, but typically now I use it mostly for revision surgery. More ideally is triceps sparing. It's more challenging in terms of what you can visualize, but the main advantage of it is they have better triceps function, but additionally you can allow them to begin use of this new replacement right away. If you're going to try doing that approach, it's nicer to attempt it to get the understanding of it with fractures, because it's much easier and simpler, because with the fracture you've taken the distal humerus out and you have a lot of space. When you're typically doing this in a primary osteoarthritis patient, it can be really challenging because there's not as much space there. So as we move along, we next cut off the olecranon tip and release the MCL and LCL. We excise the trochlea and olecranon fossa, and despite the guides that they have that you see here, which don't really work quite as well as you'd expect, a lot of times we always have a burr available in terms of shaping these in terms of moving forward. Preparing the humeral canal, this is usually straightforward with some distal reamers. And then we move to the ulna. And the ulna tends to be challenging for a couple of reasons. One, because it's particularly small, and then two, because it doesn't give you particularly great feedback in terms of where your reamers are going. So it's very easy to end up perforating the ulna with any of these instruments. So you should have a low threshold doing this to have X-ray or fluoroscopy available to check and make sure that that hasn't happened. But we begin by cutting off the olecranon tip and then using the reamer to open up the proximal portion of the ulna. Typically this is a lot easier just using a burr as opposed to the reamers that are within the system. And then we distally ream, and then we trial the ulnar component. You can trial either with an articulated component or you can keep the hinge separate, which is a little bit easier. And then at the very end, after cementing the components, we repair the triceps. And you can see that here. This is the more traditional triceps repair. So post-operative treatment, what do we do? It depends on what you do at the triceps in terms of, in the short term, we splint pretty much all of them in 30 to 60 degrees. And the reasoning for that is In 90 degrees, there's a lot of pressure on the soft tissues on the back, so by doing this, it helps reduce some of that and potentially reduce some of the wound complications. Why wouldn't we put them in complete extension is just because functionally for the patient, it's a little hard to walk around with an elbow and extension with a big splint. If we do a triceps on approach and we're totally happy with everything, especially with the hemostasis at the end of the case, sometimes I'll put them in no splint at all and let them begin range of motion right away. And then sometimes you can consider nighttime extension splitting if needed in terms of the preoperative deformities that they might have had. So here's something they shouldn't be doing, and this comes from Dr. Mori at the Mayo Clinic, and that the total elbow, as exciting as it was when it came out, there's big limitations with it, and unfortunately, we don't have as many candidates anymore now that a lot of our rheumatoid patients aren't around. But we put a limit of 5 pounds on these replacements. And so that's a limited number of people that can really have that replacement. And so that's a half gallon of milk, essentially, is 5 pounds. Revision pearls, there's a few that I like to point out to folks. Any kind of revision surgery for elbow, just like everything else, has a higher risk of infection. And additionally, with the elbow, the bones are very small, and it's very easy to perforate either the humerus or the ulna. If you're removing a lot of cement in the humerus using an ultrasonic device, you need to be careful in terms of the heat that's generated by it. There's definitely case reports of the radial nerve being injured that way, either from that device or from the cement as it cures from the exothermic reaction. And one of the ways you can avoid that is for the downside of affecting the cement mantle, but dropping the tourniquet and the hemostasis. Once you have good hemostasis with it, the heat sink from the blood flow actually helps dissipate the heat and reduce the heat on the radial nerve. But we usually advocate, if there's any concerns, in addition to finding an ulnar nerve during revision surgery, to go find the radial nerve as well, for that reason. And then additionally, sometimes getting all the cement out of these bones is very difficult because of the size of them, and we'll often, if the cement is stable, leave it alone and allow very liquidy cement laminate within the other cement. So what are the results? And we'll go into this a little bit more actually under complications, but essentially this shows that they've been successful in terms of total elbow replacements, and this has included both unconstrained as well as the semi-constrained implants. And most of what I've talked about is the semi-constrained implant. That's what I have most experience with. In the US, the semi-constrained implants, the Coonrod-Mori implant, has been primarily the one that we've used. We haven't had a lot of use of unconstrained implants. But as you can see, overall, they've been successful in terms of survivorship. But you can see a lot of the survivorship is 5 years and 10 years at most. Sanchez-Sotelo has looked at this longer term now, and they've gone out 20 years with their survivorship curves. And what we're starting to see is this is why we're not quite as enthusiastic even about the semi-constrained designs. The survivorship now to 20 years has dropped to 68%. And a lot of this is coming from both aseptic loosening, bushing wear, and overall, when you look at all the folks that they reviewed, which was about 800 total elbows at the Mayo Clinic, a third of those patients have either had their total elbow revised by 20 years or removed. So that's a pretty significant number of folks that these aren't surviving for. The other thing to note is the success rate of the different etiologies, and the challenge here is sometimes the young folks that we have with post-traumatic arthritis need a good option for surgery, but they're often not the best candidates, and there's a couple of reasons why. One is because they have high activity levels and it's hard for them to follow a 5-pound weight restriction, but additionally, they usually have an isolated joint problem versus somebody with rheumatoid arthritis will have multiple joints affected, and so they tend to be lower activity levels compared to an individual that's just isolated, injured his elbow. Following that up, Hildebrand compared RA folks versus post-traumatic folks, And essentially what they showed, not surprisingly, is the post-traumatic arthritis folks have, they all have similar subjective patient-centered outcome scores, but there really is a difference in terms of their strength when you look at the objective data, both in range of motion and their strength. And most specifically their triceps, they use a dynamometer to basically demonstrate the differences. The most recent study that's looked at that was by Throckmorton, looking again at the Mayo data, and with post-traumatics, the survivorship's even worse. Even though you see the number there is only 70%, which is comparable to the 68% we saw, that's at 15 years. And so the big issues with this have a lot to do with compliance in terms of that 5-pound weight restriction, and I'll mention that a little bit later in the complication talk. These are some of the other indications that it's been used for, and they've been successful, but there's a variety of survivorships, changes and differences. Most specifically, with elbow stiffness and ankylosis, the survivorship's the least successful, and that has a lot to do with balancing the soft tissues. And then finally, this is probably one of the more controversial topics about total elbow now, at least in the United States, that we debate about quite a bit, is what to do for the older patient that has an unreconstructible distal humerus fracture. And to look at that, the first study was done by Mark Frankel, but it was a cohort study. And so Mike McKee and the Canadian Trauma Group looked at this more scientifically with with a randomized control study. And what they basically found was for all the outcomes that they looked at, the only one that was statistically different between ORIF and total elbow was the Mayo Elbow Performance Score, and that stayed different statistically to 2 years. But everything else actually evened out by 2 years, including the DASH score. The DASH scores were different in the first 6 months, with the TEA being superior, but by 1 year, ORIF was equal to the total elbows. Now, one of the things that's a little misleading about that data is that 5 of the patients that were randomized to the ORIF group, they couldn't do an ORIF, and they end up in the total elbow group. So, but the point of the matter is, there's been a little bit less enthusiasm as we see the long-term data for total elbows, at least the semi-constrained designs, and their failure rates. And so there's been a lot bigger interest, again, pushing back to try to fix as many of these as we can. Thank you, and that's the first part of the talk.